Good morning, respected seniors and dear friends. I would like to thank AIOS and UKSOS for inviting me for this session. I will present on IOL exchange. I have no financial disclosure for this presentation, and I would like to acknowledge these surgeons as I will mention them in the presentation. So, advances in cataract surgery and IOL technology has dramatically improved surgical outcomes and decreased perioperative complications. 99% of the time, the IOL implanted at the time of cataract surgery is the one that the patient will look through for life. However, in rare cases, we sometimes need to perform an IOL exchange. The simplest and the most common reason for the patient to seek an IOL exchange is they are not happy with their initial results. Especially in routine surgery, it's when the certain expectations weren't met. That could mean the patient had refractive surprise or they didn't end up with their intended goals. Another reason is dysphotopsia in multifocal and trifocal IOLs. Then patient experience mechanical issue where the lens dislocates, possibly related to zonulopathy or trauma. Often, during the primary surgery, there might be anterior or posterior capsular rupture that may lead to IOL tilt or grossly decentered IOL. Other less common causes are opacification of IOL optic and UGH syndrome. Once we have established the need for lens exchange, there are multiple scenarios to consider. There are basically three places where we can put a lens, either in the bag or sulcus or anterior chamber. Now, capsular bag to capsular bag exchange is common for addressing lens power errors. If the capsule is torn and lens is decentering because it's in the torn bag, we might take it out of the bag and put it in ciliary sulcus. And if the entire capsular bag is dropping onto the retina, we might take the whole lens out and put the new lens in AC or suture it to the sclera. Now, basically, there are three ways with which we can do. We can fold it, we can cut it, or we can take it out as a whole. Now, refolding the lens IOL is easy, but this won't work with every lens. Like PMMA silicone can't be folded. However, we can refold acrylic lenses. The size of incision we need to remove the lens change depending on the procedure. If we refold the lens, we need a larger incision, and if we are bisecting the lens, we need a smaller incision. Once the lens is removed, we place the suture in corneal incision. In almost 50% of the cases, the ones that don't seal well. Now, this case was done because of IOL exchange was done due to error in biometry. First surgery was done 1 week back before the patient was taken again for surgery. IOL place was 18 diopters instead of 23 diopters. Main incision is slightly extended internally and using dispersive viscoelastic to coat the endothelium. With the help of dialer and repositor, IOL is brought out of the bag in an atraumatic way, taking care not to cause bleeding from the iris. Now the new lens is placed behind the old lens as a scaffold, and after this, using IOL holding forceps, having a firm grip and using Park Chang IOL cutter on MST handle, IOL is bisected and then removed in two halves. So basically bisecting the lens. In this method, the IOL cutting tip is attached to the phaco probe and its sharp edges can cut the IOL in 2 or 3 parts. Now the IOL cutting tip is such that the jaws of the forceps open and close vertically, although the tip advances horizontally. With the left hand, the IOL is held with the forceps and vacuum aspiration is kept at 0. Irrigation is low and power is between 20 and 50. That allows to cut any hydrophilic or hydrophobic IOL. So it's basically a stainless steel tip which is attached to the phaco probe. This tip attached to the phaco probe, and over it the sleeve is attached. Now another way of doing it is, in this case, it was a case again of a missed powered lens. Viscoelastic is injected in front and behind the lens, and we have to free the lens from the bag, as we do in all the cases. Now, scaffold technique is done by inserting the new IOL behind the old lens, getting it ready for extraction. We have to make sure that the new IOL is fully opened inside the bag before proceeding to the next step. So, incision in this case is 3 mm. Now, this technique was developed by Dr. Fukuoka from Japan. He uses Alcon A cartridge. is engaged to the wound and Foucault forceps are passed through the cartridge, grabbing the lens near the haptic and slowly pulling the lens out of the bag into the cartridge, making it modern lens easy extraction technique. Now, second video is modified twist and out technique for IOL exchange by Dr. Morgan Micheli. In this technique, IOL is brought outside the capsular bag into anterior chamber, and then we place a 25 gauge cannula across the anterior chamber, connecting two paracenteses. Now, with second hand, tying forceps is used to hold the edge of the optic, and then it is twisted to roll up the lens and pull it out. Incision in this case is 2.7. So, some points to consider are lenses that have been placed in the bag for a decade can also be removed. Endothelial cell count is vital investigation in these cases, and when doing scleral fixation, we should be meticulous about measurements. Glaucoma issues can be also managed along with it. And in case of negative dysphotopsia associated with monofocal IOLs, it's better to place the new IOL in the sulcus. Some issues to consider intraoperatively are procedures that is safe and comfortable in our hands should be done, and we should consider sliding the new lens via scaffold technique before removing the old. When removing a lens, don't be stingy about the size of incision. It's better to have a good safety profile. We can refresh the wound that is 2 to 3 months old and should avoid making a new one. When we need to explant the lens that has been banged for the long time, we use viscodissection or hypodermic needle is also useful. Never be forceful on removing the lens. So lastly, some vitrectomy tips, like make sure anterior vitrectomy is in your skill set. Know when to call a vitreoretinal colleague. And when exchanging the lens in presence of capsulotomy, try viscoelevating the lens. And in presence of capsulotomy, only do very limited vitrectomy. When doing a limited vitrectomy, stain the anterior vitreous with triamcinolone. So coming to conclusion, in the era of refractive cataract surgery, we need to fix postoperative problem of patient. Thorough counseling is necessity in these cases. It's important to embrace the lens exchange skill test set. IOL exchange leads to significantly improved uncorrected visual acuity. Thank you.
Thank you, Dr. Arora, for that brilliant presentation and lovely video.